Welcome to my podcast. Today I'm going to talk about another case, and it's very important, and it's very common. So after you introduce yourself to the patient, double check the patient name, date of birth. The patient will tell you, "Doctor, I'm having this sort of pain for a quite long time, and it's affecting the quality of my life, affecting the quality of my sleep, affecting the quality of my career, and just can't get around it. I just want to know what's going on." So the doctor will need to ask certain questions in order to understand the full picture of the situation of the patient. Say, for instance, you need to know how long it's been happening, and if there is anything that the patient might know as a trigger for that pain, or if there's a history of a recent injury, for instance, or trauma, or any chronic alignment, in order just to find what might be the underlying cause. So just from probing certain questions, you just realize it's beyond basically the 3 to 6 months, which will fall in the category of chronic pain, and whereby tissue usually takes time to heal in less than that period of time. So in that situation, it could be encompassed between either biomedical or biomechanical or structural, or could be anatomical process which has basically failed to subside. And this, of course, required further investigation for the chronic pain. And we need to know also chronic pain can sometimes be influenced by certain other factors like psychological or social factors, which in that regard, biopsychosocial assessment is a necessity. And the WHO has its 11th revision for diagnosing chronic primary pain and chronic secondary pain. So the chronic primary pain is usually multifactorial, which contribute to the pain syndrome, and sometimes it has no clear underlying cause, which can lead, of course, to the frustration, distress of the patient, and sometimes also with a disability, which can be out of proportion. However, the chronic secondary pain, as the name implies, it means like there's existing underlying condition, which has its impact. And in certain situations, both chronic primary and secondary can coexist together. And we know that the pain can be either constant or intermittent, and as I say, more than that period of time. So we need to assess the situation and offer a person-centered assessment in order to identify factors which could be contributing with its daily impact on the patient, daily living, psychological situation, well-being, sleep, work. If they are, for instance, studying, like how it's affecting their education. Of course, it needs some spending, so how's their financial situation? It could affect, of course, relationships, so we need to know all of that. And if there is any influence on their, like, for instance, leisure activity or any sort of activity that they like to do and has stopped them from doing so. And after we inquired about all of that, we need to understand as well the pain and ask the patient what's their expectation, the goals that we need to do and put together in order to establish a proper, tailored, bespoke management situation in order to listen or improve situation. And having said so, we need also to assess their body mass index and smoking status, and if they have taking any OTC, or if there is substance use or misuse. All of that should be taken into account. And when you come to the management, as I say, NICE guideline stated that we need to to follow the guidance and tailor to each patient with their underlying, if we have, for instance, for the chronic secondary pain, what's the underlying cause for that, to emphasize. Like, for instance, the first approach we need to do is basically understand the situation, what's the triggers, and not to start the pharmacological approach early on. And for the chronic primary pain, it's encouraging, for instance, to keep physical activity, to do a watchful group exercise, and they stated that the element of CBT is also important, but not the biofeedback technique. And they stated about also the acupuncture. Despite that it has no, it has been recently anyway removed from the pain guideline, and that's because of the lack of the evidence. However, NICE guideline has proposed and suggested a single course of dry needling can be offered in the community setting, but it's not like multiple ones, and not recommend, for instance, the TENS or ultrasound or inferential therapy, which is low frequency electric current in order to stimulate the nerve and muscle to provide pain relief and improve circulation. And we know all of those kind of machines, and I have one myself. It didn't help my pain, but I just feel sometimes just, as I say, of course, it stimulates the nerve, which causes muscle contraction, sometimes can be so severe. It's according to the volume that you use and the strength. And the pharmacological approach the NICE guideline has proposed, as we all know, which is narrowed to the amitriptyline, citalopram, duloxetine, fluoxetine, paroxetine, sertraline. It has stated that we have to have a full disclosure to the patient with their pros and cons, though the Cochrane meta-analysis had called into question of the benefit of antidepressant in managing chronic pain, so it's debatable, as you can see, and arguable. And also the NICE guidelines stated there is no role of opioid or non-steroid anti-inflammatory drugs or benzodiazepine, gabapentin, pregabalin, ketamine, and paracetamol, and local anesthesia or antipsychotic or trigger point injection due to the lack of the evidence. And it has added that if patient, like for instance, we know before those kind of things has been proposed or been used anyway, stated that those patients who are already on those kind of management, they should be explained, even if they say they had like some sort of benefit or so, so we need to offer like to tell that there is no benefit basically, and offer like a discontinuation if possible with them. And we need to know that if there is like, for instance, acceptable risk of adverse effect or intrinsic side effect, we need to disclose that as well. I recall once, because of my back pain and neck pain especially, which affecting my shoulders and my scapula, especially in between, I was sent to the bank clinic, and out of the blue, someone just popped up after the student doctor took a detailed history. Without asking anything, he said, I'm gonna numb your back with an injection in the trigger points. And he said, I might puncture your lung. And the way he approached me, it was really unfriendly and just very bizarre. I have to say, I just declined that. And now when I read this, I tell myself, good that I didn't let them to inject me, because after all, I don't like any interventional, especially when it will be like debatable later on. So I would say sometimes tolerate the pain rather than doing to yourself an injection which you know that not gonna help or not gonna stop this pain at some stage. And yeah, the just cycle goes on, so it's just vicious cycle. So from that, the NICE guideline envisages that there is no role of cannabis or any sort of its based product in managing chronic primary pain, because we know now in the news they speak about cannabis and its effect for those sort of pain. However, for the chronic secondary pain, NICE guideline has published guideline for lower back pain and lumbar radiculopathy, but not for the neck pain or its cervical radiculopathy. And there is no specific guideline for non-surgical management of chronic hip pain, knee pain, and shoulder pain. So by that, I hope that I covered the recent update about the NICE guideline and the WHO number 11 guideline for chronic pain approach and management way. Let me know if you find this podcast useful, and if there is anything you would like to add, you can comment and I will get back to you. Thank you.